when Rajendra asked me to be on several panels as well as speak, I'm confident people will get sick of seeing my face. So that's not my fault. It's his fault for inviting me to do all these things. This is a really interesting topic when you think about it, because it's orthogonal really to digital health. Yes, digital health will affect how specialties evolve, of course, but they're all their own beast. And so I tried to think of a way to set it up, and I came up with two themes, which I will speak to here in a moment briefly. Then I'm going to ask Cella, who's seated next to me. Well, I'm not seated yet, but next to me in the chairs, to come, and he's going to give a more extensive talk. Then each one of the other panelists will introduce themselves, speak for about 5 minutes, and then we'll see where we are. If we have time, I'll ask some questions. If we're running short on time, we'll have your questions. So as these people speak, be thinking about what you would want to ask them. It is an impressive lineup, I have to say. So I'm delighted to even be on the stage with these people. So the future of medical specialties, the way I looked at it when I was thinking about how to tee this up was that there's two angles to this. One is that as we look at digital health and how it affects how we provide care, how we make diagnoses, how we create care plans, how we interact with our patients, some specialties are already way ahead of us. So for instance, radiology was doing AI before most of us even knew that it was a concept. Likewise, by the way, they were doing telemedicine way before the rest of us caught on to that. When I started doing telemedicine in the early 90s, radiology was already way ahead. So because of the nature of their work, they tend to be ahead in this, and because they deal with images, and images are great data sets for AI, they've really been ahead. Likewise, pathology, because again, very image focused. And then you get into maybe endocrinology, because there's so much innovation in how we use data to manage diabetes. Beyond that, I couldn't think of any particular relationship. And again, maybe my colleagues will come up with some different ideas, but I couldn't come up with any particular relationship between medical specialties and digital health. Some maybe less interested. I think maybe those of us that are procedurally oriented, because we're so focused on doing procedures, may be less interested in this area of innovation. We'll see. The second way I thought of looking at this was that it's fundamentally changed the way we interact with our patients. Patients come into my office all the time now. They think, and many times they're right, that they've figured out what they have. And they're testing me to see if I have done my Googling or ChatGPT or whatever it might be, and then I'm not just an old guy with white hair who hasn't caught up. So interacting with people in that environment is so different than it used to be when my professor, who was a prominent dermatologist in the US in the 20th century, would take his textbook off the shelf and show the patient the chapter in the book. We don't need to do that anymore. The book's online. Patients read up ahead of time. So how we as medical specialists interact with our patients in the context of this, we no longer have information asymmetry. That might come up in this discussion as well. We'll see. So those are my thoughts, and I can't wait to hear Cella give his talk, so I'm going to give him about a minute longer because I haven't used my 5. So welcome to everyone. We're going to get a really good panel out of this, and I'll be back when I have questions to ask.
Thanks, Professor Kvedar, for the introduction. It's a pleasure to be here at the GDHS in Mumbai, and I really appreciate the chance to discuss about the future of medical specialties and how the evolving technology can really help us to improve clinical outcome and how also our clinicians are working. So to put a bit of context on the challenge that we are facing, we do know that there are several areas that create a lot of inefficiency in the healthcare system. There are 750 billion spent in unnecessary care around the world. 10% of the cause of mortalities are due to adverse drug event, so that can be avoided. And there is also 27% of the patients readmitted to hospital due to deemed avoidable decisions. So this is creating really a huge cost of readmission, cost of errors. And we know that many of these mistakes can be avoided. So this is not just a big cost, but it's also affecting the daily life of clinicians. So clinicians today, and we talk most of the time about the second COVID wave, are facing a huge clinical burnout. So they are increasing burnout. This is increasing the risk of shortage of healthcare professionals. And this burnout is also due to increasing documentation, increased technology that is not set for purpose, and a huge pressure to make decisions very fast with the risk of having a risk on accuracy in care. So we see also that there is a big push to use new technology, but this needs to be grounded in trustworthy content. So there is a high demand for standardization in care, and this standardization in care should be grounded in trusted clinical information. So this is in India even more, I would say, visible, because the healthcare segment, both private and public, has set very high goals, such as standardization of care, monitoring more the data on the patient, integration with HR, analytics. So you're really trying to step up as a country to evolve to the best care possible. And also you want your doctors to have continual medical education. But the setting is still facing a lot of challenges because the integration is still not, the deployment of technology is still very fragmented. The healthcare IT ecosystem is broken in many parts between outpatient and inpatient care. And there are no guardrails, and this is true also in the US, between balancing speed and accuracy of information. So this provides a risk on the care that is provided, and the pain persists in the delivery of care. So our vision as Wolters Kluwer is to try to really step up, and particularly thanks to the AI technology, to build a clinical intelligence that can be the central nervous system of healthcare. So Wolters Kluwer and UpToDate have provided since many years the clinical decision support to thousands of doctors, millions of doctors around the world. But now with AI, this experience can be deployed even better, because we can really provide a faster answer when clinicians have questions based on clinical accuracy and safety. So how can we do it? Really providing a quicker access to the physician and to the extended healthcare professional, including the nurses, thanks to AI-enabled and generative AI search. And we can provide this type of information more integrated into the workflow. Not just to start from the EMR, but not just that. We are really testing also in ambient environment this possibility. And why UpToDate is so uniquely positioned to provide a safe AI answer to the physician? I want just to give you a flavor of what has been happening in the last 30 years before moving to the future. So in the last 30 years, UpToDate has been created and has been building evidence-based content through the contribution of more than 7,600 doctors around the world in all medical specialties, through practicing doctors working in the best hospital around the world. And this has been a tremendous success because as of today, there are more than 3 million doctors using our solution in 190 countries, more than 700 million of time per year. And there are studies from Harvard University that are demonstrating that each time that a doctor is using solution for clinical decision support, such UpToDate, they change their decision 1 out of 3 times. So let's think about what can be this impact for India. Today, which we are at the top of the iceberg, we have already 11 million topics viewed per year in India across 400 institutions, which if you just make basic calculation per day, you have 30,000 patients that are used, that are treated consulting UpToDate, and probably 10,000 patients per day are treated differently based on the best medical, evidence-based medicine. So, impactful, but your population is so wide that we cannot just imagine if these solutions are adopted at the central nervous system of the healthcare system of India, how much more population can benefit of this. So it wasn't easy for us to step up in AI because we needed to do it very trustworthy. We wanted to keep providing a true answer without hallucination to all our users. So in the last 2 years, we have been testing in what we call the AI lab, and together with partner, clinician, and major hospital system, how our generative AI could have worked and could work in the correct way. And right now, we have launched what we call AI-enhanced search, so the clinician can check UpToDate content with more colloquial system to search, but it's not where we stop. We are right now in the verge of launching in the US to test with many hospital settings what we call UpToDate AI. UpToDate AI will be the first version of generative AI of UpToDate, but fully working just on the UpToDate content, and with a lot of guardrails put in place to confirm that the information that is retrieved and provided to the clinician is right. And with that, I think we are turning to the second area in which we can provide support to the vision of India to improve the healthcare setting. So the number that you have seen are quite astonishing, right? 730 million of views of topic around the world. Can you imagine this data set, how can be beneficial for the hospital administrator, for the public department of health across the world, to understand how clinicians are searching information into the system? We can really analyze all this wealth of data, and again, thanks to AI, but from a different angle. AI helping us to understand trend, AI help us to understand what are the clinical knowledge gap within a hospital settings. We can really help the administrator to take decision on the clinical workforce, to keep expanding their knowledge and keep expanding how they can take better decision and how can improve decrease variability of care. Because if you have multi-site or multi-departmental hospital, you can start checking by site, by department, how UpToDate has been used. And I just want to give you a case study that we were sharing even internally with our team of one of our partner, which is the Ministry of Health Spain. So this is a history that is along 10 years. We have been working together with the Department of Health Spain. UpToDate is provided to more than 400 hospitals and to all public servants in the state, and there have been more than 30 million of topics viewed since 2026. So what happened? We have built a national partnership for better outcomes. So we can provide populational health insight given million of usage topics. So we can compare, as I was saying, region, gap analysis, benchmarking, and health strategic planning for the Department of Health. But we also were able to identify early warnings. In Spain, just 1 year ago right now, there was a huge flood in Valencia region with hundreds of people that died. And we were able to see a spike in the review of the leptospirosis topic. So in real time, communicating with the Department of Public Health, we put in place rapid response, supporting resource allocation and training of the latest evidence-based recommendation for that type of disease. So this is really what can happen, and the next level is partnership, so integration in the workflow. So we have communicated lately several partnerships, particularly with ambient solution. One of the burdens that I was mentioning is clinical documentation for doctors, reducing the time exposed to the patient. So these technologies are blurring in the US and in many parts of the world. I was visiting a hospital yesterday that is testing this technology here in multi-language. And they want to have a clinical decision support within that. So that's it. Thanks a lot for your support, and I just want to finish with a short video.
Imagine your hospital's clinical intelligence support works like a central nervous system, integrated, responsive, and trusted. That's the future we see. Over 7,000 expert voices from UpToDate embedded directly into your workflows, enabling better decisions the moment they're needed. Trusted intelligence, activated by AI, and grounded in decades of clinical expertise. As care grows more complex, your teams need more than tools. They need a partner that anticipates, adapts, and evolves. UpToDate is that partner. We're not just keeping up with the future, we're helping you lead it. Join us in building the care system of tomorrow.
Thank you.
So we're going to go down the line now. My colleagues are each going to spend roughly 5 minutes, one just to say who they are and to give their views on this topic of medical specialties and the future of medical specialties. And then I will have questions, but if we get towards the end, as I said, we'll defer to your questions first. So please, Ali.
Thank you, Joe. I was not a very good student, but I remember one thing my professor said, which is if you talk too long, people fall asleep. So I try not to be the 5 minutes. My name is Ali Parsa. I'm the founder of Quadrivia, which is an AI company. I'm a serial entrepreneur in healthcare, sometimes successful, sometimes not so, the story of life. On this issue of AI and specialties, before we even start on this, I think we should remember we're in India, a country in which we have some of the best healthcare in the world, and yet some of the most inaccessible and affordable to many healthcare anywhere. And that's the story of healthcare globally, is inaccessible and unaffordable for most. And the reason it is so is because in healthcare, we have a structural imbalance between elastic demand. My child gets sick, I will spend any time, any effort to try and fix the problem. And a very constrained supply of clinicians like yourself, Joe, globally. And while AI cannot solve that problem, for the very first time, it gives us the promise of creating elastic supply of clinical skills. And it's in that promise that sets the dream of making quality healthcare accessible, affordable to everyone on Earth. It's that mission that AI can empower. Against that mission, of course, it's the hype that where is AI today? How far can it go today? How much can it do today? That's something for us to discuss. But I just encourage us to remember that the goal, the mission in here, the promise of AI is to make healthcare accessible and affordable for everyone on Earth by addressing the root cause of inaccessibility and unavailability, which is the imbalance between supply and demand. And we can talk about that further.
It only recognizes Ali's voice, which is right. So for me, this question of future of medical specialties has multiple dimensions. And I'll be factual on that. Some of the specialties have already got impacted. Radiology, general physicians, family physicians, dermatology. Some will get impacted over time. And I think also new specialties would emerge. You know, the disorders coming from the digital world will need new specialties. I can bet you that will happen. But what I find will be very interesting for all specialties is shared decision making. I remember it was more than a decade back that me and Shashank were medical advisors to Mayo Clinic's joint collaboration on developing a patient portal. What I learned that patients, when they work through patient portals and joint shared collaboration, like shared decision making, they would change the very way we treat patients. And also on my right side, Ali and I are working on Quadrivia. I see immense possibilities what AI will bring to specialties. I think what I like is that continuity of care model will flow across specialties for an individual specialist. That you will actually start working, collaboratingly with other specialties through AI. As I said in the morning that there are 5 levels at which healthcare will transition to. It'll be wrong for me to just paint a rosy picture. Yes, there is a golden age of medicine coming for specialists, for journalists. But yes, increasingly we will start moving towards self-care over time, whether it is 3 years or 5 years, which time will tell. But AI will give more power to patients. Though there is always a doubt in terms of what level of accuracy it will have. But I think what we are seeing in our work is that it will be fairly accurate. So the future of medical specialties, some will cede their power to the technology fully, which is mostly driven by the general ailments. Some will become shared decision making with AI, with patients and the specialist. And some will, kind of move towards a multi-specialty ecosystem. And I think 3 specialties clearly for me stand out: dermatology, radiology, general physicians. But more specialties like surgery is moving with robotics. We couldn't have Shafi, he couldn't get visa, but I can think that more specialties will start using AR, VR. Gaming, I see Oli is here. So it's an interesting time. I don't think that we have an accurate prediction, but we're going to change the way we look at medical specialties, and more power will move towards healthcare over time. Thank you.
So I'm Shashank Joshi. I'm an endocrinologist, diabetologist. First of all, thank you, Dr. Rajendra, Pratap, Gupta, to continue this momentum. As Charles Dickens said, we are in best of times but worst of times. We are in best of times, particularly post-COVID, because I think COVID was a huge leap in telemedicine and digital health. And I think that truly allowed us to use digital health to the next level. In endocrinology or diabetes, information, radiology, pathology, I think AI is right up there. But when it comes to complex decision making, we are in worst of times because we have too much of data and clutter. And sieving that data still needs a human mind and still needs a clinician behind the scenes. We have some excellent experiences in lifestyle medicine. You can't make generic advices like eat more, sleep less, sleep more, walk more. You can actually personalize care. So when you're personalizing care for that individual, because of heterogeneity, because variability is an inherent characteristic of the biological world, and we are all operating on a normal or a Gaussian curve. So we are a probabilistic science at 95% confidence limit. And that is where maybe AI has a role to make a probabilistic decision-making support or shared decision-making. It gives us the cues as a doctor to help people living with diseases like, say, diabetes or obesity better. We can definitely look at preventive strategies, remission strategies, therapy strategies, and also ensure that who will be a responder, who will not be a responder. So putting them through risk scores. We have done the biggest challenge which I see in AI is generation of high quality evidence. I think that is the biggest gap which I see. We have done some randomized control trials, for example, with a diabetes remission program in Bangalore. We replicated that now and published in AGM Catalyst with the Cleveland Clinic. But, it's a long way to go. So I think there is a data clutter. In the medical specialties like diabetes where numbers are involved and big data is required, or endocrinology, maybe, or radiology or pathology, they have evolved quicker. But my colleague, Dr. Anil Nayak is here, and I'm sure he's an orthopedic surgeon. Over there, it's a long way to go. I mean, to fix your fracture, you still need your instinct, you still need your decision-making skill, and you might get some direction from AI. So I think it's an evolving science, but all of us have to adapt it. And the second biggest game changer beyond COVID has been the smartphone and the wearables. I think the smartphones and wearables are changing the way we look at overall preventive health, future health, and living longer. So I think we are here to stay. And I personally feel very passionate about the entire science of digitalizing healthcare with a human touch. Thank you.
Thank you, Shashank. Let me try and take you back about 35 years. And when we started radiology, I'm a radiologist by profession, an interventional radiologist. In the sense, I treat only blood vessels which are either bleeding or blocked. So when I started doing or studying radiology, it was an analog era. I have seen every film as an analog film, the dark room techniques. Radiologists were never in the front line. But once the digitalization happened to radiology, that was way back in 1990 and beyond, the entire process of patient diagnosis, patient treatment, looking at the entire clinical history and correlating with radiology findings entirely became so natural that patients were given a treatment, a precision medicine was given, so that the waiting period for diagnosis as well as the outcome of the disease was much slowed down. Then came obviously the era of CT and MRI. And as you know, CT and MRI are going to be the front runners of diagnosis of any disease in the body, both functional as well as anatomical. So radiologists are not there as image readers. They are basically now they will become integrators of all patient data, including the image, including the clinical history, incorporating the pathological findings, and trying to give a diagnosis which is much more smarter than what they did 25 years back. Now, when I say radiologists are integrators of patient data, AI is going to play a major role in all this. And when I say AI is going to change the way that a clinician is going to interpret a radiology image or a CT scan or MRI, I mean the interpretation of data is not going to be what anatomy that I am describing, but it's going to be actually the prediction of biology of the tumor from radiology or radiological images. So this is going to be the future of radiology. The baby right now is interventional radiology, as everybody knows. Try to do everything in a minimally invasive way. Try and guide with precision, with laser-guided pinpoints, and maybe in future, all the angiographies, including the coronary as well as the neuro interventions or the peripheral interventions, will all be done by robots. And mind you, the robotic radiologist or the robotic cardiologist will in fact guide or do a procedure about 100 kilometers away from his place of work, or maybe 200 kilometers, or across the globe. So what we are trying to do is democratization of radiology, or democratization of clinical information that we see today. The entire data set of a patient is going to cross borders, and teleradiology is one of them. But to tell you frankly that teleradiology is not a standard way of reporting. In India, what we do is just an initial reading of images, either from US, Canada, Australia, other places. But what is going to happen is we are going to cross borders, read images, and see to it that the turnaround time for image reading is less than 30 minutes. You do a CT scan and the image and the report should be ready within 30 minutes. One more point that I would like to mention here is that what we are trying to do today is going to affect millions of patients worldwide. a new entity which has come in radiology is called as preventive radiology. Anybody heard of preventive radiology? None of the hospital packages, none of the clinical packages will have preventive radiology. They will have each test as a separate one. But mind you, if you do carotid intima media thickness, if you do ankle brachial index, that is ankle versus the brachial ratio of blood pressures in the systolic manner, or if you do the widest diameter of the aorta in the abdominal aorta by ultrasound, this is going to change the way that clinicians are going to see the patients, and longevity is probably the ultimate goal of each and every clinician. So at the end of the day, radiology is about patients, people, passion, and definitely a predictive science where we are going to predict how the biology of the tumor, how the disease process is going to affect the patient. Thank you.
Good afternoon, ladies and gentlemen. I am Colonel Dr. Mohan Kubendra, the National President of the Academy of Family Physicians of India. And I represent the new generation of family physicians who are mostly residency-trained doctors in family medicine. At the outset, I would like to thank Dr. Rajendra Gupta for giving this opportunity and recognizing family medicine as a specialty. Before I talk about the implications or the impact of AI on general practice, I just want to give a brief historic perspective and about the changing paradigms of primary care. Traditionally, you all are aware that we only had the family doctors who were taking care of almost all the healthcare needs of the society. Almost till the mid-80s, we had only family doctors and a few basic specialists. With the rapid advancement and fragmentation of medical profession into specialities and subspecialties, the family doctor was pushed to the rug, and we almost reached the stage of family physician being extinct. But the silver line is that it is coming back. The national health policies over the years have always identified a comprehensive physician or a primary care physician as the focus area. In 2002 National Health Policy identified family medicine as a focus specialty, and in 2017 it was further amplified, and National Medical Council has recognized family medicine as a specialty. But what, as far as I am concerned, the catalyst is the COVID pandemic, I think, which brought the focus back on the family physicians. When the media was either praising or criticizing the way the critical cases were managed, it was the family physicians and the primary care health force which were relentlessly working to prevent the hospitalization of cases. So there has been a shift in the way primary care is provided now. There is a shift from illness to wellness. Now you have wellness-oriented care, mental health integration in care, digital health integration in care, patient-centric care, and the community is looking for a physician who can provide a comprehensive health care to all the members of the family, from children to the elderly people. And the new age family physicians who are qualified in family medicine are now responding to these new dimensions of primary care. The implications of AI in general practice is no more speculative. The patients are already using the AI tools. They are coming to the general practitioners with the huge amount of health information, with the confused patients are coming back to the trusted family physicians for giving a personalized or a contextualized interpretation of the information. And as Dr. Rajendra Prasad already mentioned, that most of the specialties of the medical profession are implicated or disrupted by artificial intelligence, majorly radiology, pathology, dermatology. And I am seeing that the medical profession is going to face a huge unemployment crisis, I would say, with almost 120,000 medical graduates passing out every year, competing with each other to get into specialties. And now they have to compete with the artificial intelligence, the agenetic AI, or the virtual workforce. So, but ladies and gentlemen, there's one thing which AI cannot replace. That is human touch, empathy, care and trust. That is what the family physicians stand for. That is what family medicine is all about. So I feel the future of healthcare will gravitate back towards general practice, provided the general practitioners adopt to these changes. Otherwise, there is a risk of the patients losing trust in the family physicians if we don't adopt this evolving change, and if we are not trained or educated in how to use artificial intelligence in a practice. I think we will lose the trust of the patients. So I feel AI is a good empowering and augmenting tool for family physicians. It can never replace the family physicians. It can only augment. They can probably act as a co-pilot, can never be an autopilot. Thank you.
Thank you. I am Dr. Anil Nayak, practicing orthopedic surgeon and President-elect of Indian Medical Association. As you know, Indian Medical Association is the world's oldest and largest association of modern medicine doctors. I am thankful to Dr. Rajendra Gupta and our President of Indian Nursing Council, T. Dilip Kumar, for giving me an opportunity to remain present in this era. Everybody know that here in India, basic degrees are MBBS, then specialties are MD and MS in various specialties, and then super specialties like DM and MCH, in particular cardiology, neurology, and plastic surgery, everything. So, as far as the future of medical specialty is concerned, it is rapidly evolving, driven by technological advancement, shifting patient needs, and changing demographics. I am giving because India is the younger country in the world. More than 40% population of India is between 25 to 45. So as far as the future is concerned, many specialties are there, but we have to work on different new specialties as far as future of India is concerned. One is longevity specialist, because focus is on the helping patient maintain or enhance their health and quality of life as they age, preventing or minimizing age-related diseases. That is important as far as the age-related patients are going to come, because average lifespan of a male when we get independent in 1947 was, for female it is around 40 and for male it is 35. But nowadays, as far as the last ratio is concerned, it is 65 for male and 70 for female. So India is going to be a country of old age home. So that is why such type of specialty will be required. Second thing, many non-communicable diseases are lifestyle diseases like diabetes, hypertension and this. So for lifestyle medicine specialists we need in future, trained to apply evidence-based lifestyle modification such as dietary changes and physical activity regimens to prevent treat, and reverse chronic diseases. Third one is cancer immunologist. In future, as you know, diagnosis and treatment of cancer day by day increasing in India. Cases of causes are well known to everybody, but cases of carcinoma is increased day by day. So cancer immunology specialty will be required in future. They use the body's immune response to combat various types of cancer with potential to improve outcome of certain kinds of cancer. So such type of, and there is clinical informatics specialist, which will be the future necessary specialty. They will optimize the patient data to guide clinical practice, combining medicine, information science, and computer science. So growing demand of such type of specialty, we will think regarding such type of gerontology, genetic counseling, palliative care, regenerative medicine, such type of specialty will be needed. In gerontology, by the aging population, this type of specialty will be demand in future. Genetic counseling is important. As the genetic testing become more prevalent, genetic counselors will play a crucial role in helping patients understand and manage genetic risk. Palliative care. Palliative care specialized will be needed to provide comprehensive care to patients with their serious illness. And regenerative medicine will be also a future specialty. This will involve repairing or replacing damaged tissues and organs with potential application in treating spinal cord injuries, heart diseases, and certain types of blindness. So such type of specialty will be required in future. But we have to change, because those who change after change will survive. But those who change with the change will success. But those who change, lead the change, will become the leader. So digitalization and Digital India is the program of our Honorable Prime Minister, Shri Narendra Bhai Modi. So in medical field also, we have to use all the AI digital program for our diagnostic purposes and assisted in operative technique. But for clinical diagnosis, human touch is important, and patients of India is mostly satisfied not with the diagnosis and treatment, but with the human touch of doctor. It is important. So I request everybody, digitalization is important, but don't forget have a clinical touch and human touch for better treatment and better future of the patient. Thank you very much.
Excellent. Well, that was a show of force with all of these really interesting perspectives. I have some individual questions. I wanted to disclose to our audience that I did not get a chance to meet everyone, so if I refer to you by your specialty or your role, please don't be offended. I just don't know everyone's name. But I want to start with Rajendra. After all, it's his conference. You outlined this morning, I think it was 5 levels. And each level you had a comment about who might be displaced. Have you thought about which specialties you think are at most risk for being displaced soonest? And the second part of the question, and by the way, anyone can, once he answers, I'd be happy to take any other panelists' thoughts. But the second part of the question is, will new specialties be created? So who might get dumped first, and will the new specialties be created?
Thanks, Joe. I think very clearly, Dr. Mohan Kubendra, is very bold to accept family physicians first. They will be the first ones. They are actually the first ones now.
Sorry, I didn't hear
the
it.
general physicians, yeah.
Interesting.
As we speak, we have been testing a program on patients. Is accurate to the point of telling a patient you have migraine and this is the medication you need to take. So you can understand the short answer is every specialty will get impacted.
Right.
If we get deeper into, like I showed the 5 levels, every single specialty as we move from talkers to thinkers to doers, innovators, and leaders. Every single organization, that's why I said the three-tiered health system would be gone. That's the fact. And I'm sure that we should have that moment of truth. As I also said, ignorance, arrogance, and pride have same results in the digital age.
Right.
Technology will not seek your permission. So what we are doing, let me also tell you that what we are doing for general physicians, we are working to create a brain health program, because more and more problems will also come when the patients walk up to you. You should be able to cater to them. So every specialty will have to cross-skill, not just upskill. That's where they will become much more indispensable in the age of AI. That's what I would stop with. Thank you.
I'm going to give my colleague from family medicine a chance to respond, but I wanted to just share that at our organization, and I mentioned some of this morning, so the first AI tool that kind of blasted through was this ambient listening technology that I described, and I think not very controversial, as long as the person who's providing the care has the time and brains to review whatever draft that the AI comes up with, it should save us time. By the way, that's not been proven yet, but people seem happy with it. But the second thing we're doing, and I think this is just starting, but it was interesting to me, is to use some AI agents to deal with some patient questions that come through our patient portal in the context of primary care, because the primary care doctors feel overburdened with patient messages. So I heard 2 or 3 people speak to caring and human judgment, which I make those comments when I'm on the stump myself. But if we start to use bots to do that front-end work, are we going to erode that caring relationship? So anyone can respond to that, but I thought interesting that you said primary care, and I see them at risk as well, but down at the end of the group, I know there's some thoughts there. Please, anybody?
So, no, I don't agree that primary care will be replaced fast because unless we adapt to these changes, we accept and adopt, then there is a possibility that the patients might lose trust in family physicians. They might start thinking that if you're not able to respond to their queries from whatever information they're getting from the artificial intelligence, if you're not able to respond to that, there is a possibility that the patients might think that AI is more qualified than the family physicians. Okay. So what is very important here is that to define the role clearly for the artificial intelligence as far as general practice is concerned. They can only augment or empower family physician. They can never replace, as I already mentioned, that the AI can never replace the human touch, the care, and the empathy. So we have to clearly define the role for AI in general practice.
So I want to give my colleague at the very end. Did you have anything to say from the Medical Association perspective on this matter, or because there's other people that are chomping to talk?
IMA is always in favor of modern technology, and we are promoting it because technology is important. It will lessen the hospitals and everything. And what impact of this technology will impact, that is our artificial intelligence will revolutionize the diagnostic, personalized medicines and patient care, improving accuracy and efficiency. That is why AI. One part I forget regarding the telemedicine. Remote consultation and monitoring will become increasingly important, expanding access to care of rural and undeserved areas. And so such type of technology we are promoting, and gene counseling also. So we are in favor of digitalization technology. That is right thing. And that's why I'm telling you, with the time you have to change yourself, you have to go with the technology. That is the aim of the modern medicine doctors. Thank you, sir.
Thank you. And you, sir, go ahead.
So I think AI just assistant like a physician assistant or a surgical assistant. No specialty should view them as a threat. We have to integrate AI as a part of our decision-making tool. I think that's the best way to put it. There is no threat. It's time to embrace, and it's time to move on with it. And I think that's what he's also echoing as IMA, that we need to embrace, earlier we embrace digitalization of health, the better care we can give and more remote care we can give. So actually it can improve efficiency, it can reduce time span, and I think overall the outcomes will be better.
And I think we would all agree with that, right? That's, in fact, that fits into your up-to-date vision as well, right? The wonderful automated assistant at the doctor's beck and call. And I do have other questions, so I'm going to leave this one open because I think it won't be solved in 5 minutes. I just want to say again that all of that is true, but at our organization, they've decided to put AI in front of the doctor to answer questions, and I just don't know that that's the right thing to do. We'll see how it works out. I know, Ali, you had a comment, and and I have a question for you. Okay, well then I have a question for you. You spoke about AI giving us an elastic supply of clinical skills. Can you just unpack that a little bit? Tell us more what you meant by that.
Sure. Joe, think about when you went to the medical school. Think about when somebody comes and visits you as a patient. What happens? Before even they come through the door, what they're seeking is the vast array of knowledge that you collected through your years in medical school and then afterwards. The reality is that AI can learn that incredibly comprehensively today and remember more than a human mind can. So access to that knowledge, not the interpretation, but that raw knowledge is something AI can help with. It's a medical skill, clinical skill they can do. Then they hope that before they come through the room, you have read their medical records and are familiar with their history. Now, you and I both know vast majority of doctors don't have time to at least do that in full. Then they want to talk to you and ask questions. We are in India, in an average third city in India, the length of consultation, I believe, is only 2.5 minutes. So no real consultation can happen in that period. It's not because these doctors are bad, it's because there is an imbalance between. But AI can talk to you for hours, if you wish, and ask all questions. And you can go down the line. I don't want to take this too long. But if you unpack it to 10 basic steps, then you create hypotheses of what could be wrong. 5th, you will ask them to do some investigation. 6th, you will refer them to the right specialty. 7, you diagnose, then you prognose. And what you see is almost in every one of these steps, there is clinical skills that AI can do very well, which in a way creates an unlimited supply of those skills because AI can be massively scaled. But in a way, none of those things AI can do that well.
Well, that's right, yes.
And that well. And that's where somebody like you should come. So this hype that is AI going to replace a human being, I just think maybe one day, who knows? But at this stage, it's great for journalists and great for futurists to make a living out of. I think in real life, it's more complex than that.
Yeah, no, I think, Rajendra, when you have this conference next year, there will be examples in the marketplace, and maybe there already are, I don't know, but of AI agents with no human in the loop. Right now, that's the other theme that I hear is human in the loop, which I'm a big proponent of because, as I said, if there's a hallucination in the beginning of that agentic flow and it screws up my patient's outcome. And by the way, if I'm not smart enough to look, double check everything in the US, I'm liable for that. That's another angle to it. But I think it's happening, and I'm not sure I think it might be that the cat's out of the bag or the horse is out of the barn, but I worry a little bit that we're ahead of ourselves. My next question is about radiology, and I'm sorry, I don't know your name, sir, the radiologist. I'll tell you a little parable. When I started doing this work in the mid-90s, The big controversy at that time in the US was that radiologists had a rather good lifestyle and they were rather well compensated. And they sort of said, you know, I kind of like my lifestyle. I don't really want to read films between, 5 p.m. and 7 a.m. in the morning. I'd rather go home to my family. And so we started hiring people for much less money in places like New Zealand or India or the Philippines, and radiology reimbursements went down as a result. So in my opinion, they kind of cooked their own goose because they were too comfortable. Is that same sort of thing going to happen with AI? Now, I have to say, Rajendra, I would have predicted you would have said radiology, because it's all image focused, images are data, and I think sooner or later, I'm not a radiologist, but I think sooner or later, the computer's going to do a pretty good job of making those diagnoses. So, question for you, and again, I'm sorry I don't remember your name, but is radiology at risk for being displaced in one of Rajendra's 5 areas, and what do we do about it?
As I understand, are you trying to imply that radiologists would be replaced by AI?
Yeah, by AI, yes.
Yeah. I think the fear is unfounded for the simple reason that AI is going to teach me a lot of radiology eventually. And AI is going to predict what the disease is likely to be. And we are not just going to be diagnostic physicians henceforth, but we are going to be interventionists, as I said. Okay. And the future radiologist is going to have hand skills, that is how to puncture an artery, how to puncture a hollow organ, but they are also going to be integrators of data of all other specialties. So at one place, he is going to integrate the data and come to a diagnosis with the help of AI. One who adopts AI will survive. One who doesn't adopt AI is going to perish.
Yeah, thank you for that. And again, these are deliberately controversial questions, so I don't mean to put anyone on the spot, but I'm trying to point out just that we're at an inflection point with this stuff, and it'll be interesting because, as was said multiple times this morning, it's moving pretty fast. I have one more question, and then I'm going to open it up, so people get ready, and we'll take your questions here. But my question is for you, Christian. We use UpToDate, and sometimes I find it a little hard to access, whereas Google is right there, Gemini is right there. And I think you spoke to this somewhat, but how do you position UpToDate so that it doesn't get commoditized by other agents that are out there, just easier to access?
Yeah, very good question. And this is what I was calling UpToDate AI. So next week, bit of a spoiler, we will communicate in the US availability in a limited number of hospital system in the US. And it's more of a ChatGPT type of experience, right? So it will be totally generative AI, grounded into the current content, wonderful. So reducing the hallucination risk. But it's necessary because we do see a behavioral change in the young doctors, particularly.
Yes.
And the philosophy we have built is to try to maintain a bit of clinical thinking. So when you prompt, the answer will be based first on assumption. Did I get it right? Is it a pregnant woman? Does it have any comorbidity? To help still maintaining a bit of clinical thinking in the answer.
Thank you. I bring that question up because
can I make a comment?
Can I make a comment? Sure, please. Yes.
So I have been an UpToDate user, from last 25 years. It is very difficult for a Gemini or a AI tool to replace it for 2 reasons. UpToDate is validated and vetted by domain experts in that area, while the Gemini is not vetted by anything. So I am not sure what information is coming out is garbage. Is it really vetted? Is there appropriate reference? There is no background check on it at all. And I think that is the human element which I'm talking about, that if you don't have a group of experts filtering out that information, you will have a disaster. And UpToDate went 2 steps further. They went and generated their own analytics and their own outcomes, doing some science and data. So the biggest problem with AI is AI needs to generate its own evidence base in the way we look at evidence-based medicine, and not just some, output. Information sieving is an art. And I think UpToDate was one of the first ones to do that correctly and appropriately. That's my take on it. Sorry for the interruption.
Excellent. Did you want to respond?
I think we call it responsible AI, right? So it's clinically vetted. So that is, I think, makes the difference. And for this took us a bit longer to have that in the right place.
So the reason I asked that question, and again, the dialogue bears out the tension, which I've seen multiple times over the years, between a technology that is consumer grade but really easy to use versus a technology that is more secure, maybe more expert, like UpToDate, but is a little just harder to use. And I find patients and providers, and they don't tell anyone. So the other example of this was, for years, people would text message back and forth as doctors and nurses and whatnot, which is, of course, not protected at all. Hopefully, we weren't using particular patients' names, but probably there were pictures, names. But it was just easier than going into the electronic record and dropping in a note and waiting for someone. So I just think how this evolves will be very interesting, because I'm delighted that you're going in that direction. I think you must. I just would my plea would be make it so easy to use for us, because it's a little harder to get to sometimes. Okay, I'm done ranting. I'll take questions if I can see people at the mics.
Thank you for a wonderful panel here. I have a question for Dr. Kubendra. So AFPI has been a very important pillar to train the physicians. And with digital health and AI coming in, how do you see that AFPI can work with startup founders like me who wants to build an additional layer of digitally enabled workforce that can be part of what startups are bringing as a tool, and then working with the AFPI trained medicinal workforce? So not only just leveraging your association, but also building new roles, especially in women's health going forward, which is going to be much more needed when it comes to personalized healthcare.
So AFPA is definitely for digital literacy among the members, and we are already collaborating with some of the startups. Especially now, for the time being, we are collaborating with EMR platforms. We are encouraging the members to use electronic medical records. And also, we have been conducting workshops at various levels, even at the global level. Like WONCA is our World Organization of Family Doctors. The World Family Doctors Conference is right now happening in Lisbon. So there is a collaboration at the global level, and even at the national level, AFPA, we have collaboration with the AI platforms and the startups. And we, on a very regular basis, we conduct the workshops on AI literacy. And we have an MOU with the Health Parliament and with Dr. Rajendra Gupta's thing. So we are working towards evolving probably a course in AI for the general physicians through this agency. Thank you.
Other questions? Yes, yes. I see the mic runner.
Hello.
Yes, sir.
Yeah, hi, my name is Abhijit and I work for Oracle Health and AI. So and thanks for the very engaging discussion and a lot of inputs to take from the discussion here. If I go back and put in some analogy in terms of how not just AI, but technology has changed the overall human or consumer behavior, right? Nobody like 25 years ago or 20 years ago would have imagined that there would be driverless cars, right? It's happening now. Probably 5 years from today, India would see a lot of driverless cars here. Nobody would have imagined that I don't want to carry my wallet with me, that it's an invisible wallet somewhere, wherein I could have cash deposited, right? But that's happening. That's happening with a lot of technology advancements. And being a part of health tech from a very long time, I see it's going to impact health care and care providers there as well. I want to make an argument and I want to understand your thoughts around it. What we have understood is an average person annually, or not annually, in a lifetime makes about 250 hospital visits. And out of that, there are close to 50%, like 100 to 125, actually need doctor's intervention. Right? The rest could still be augmented with AI. And I'm not saying it's going to replace the doctors, but the hospital visits or the revenue that could be generated by the hospitals or the bottom line costs and stuff like that, right? Probably there could be an impact on that. So I just want to understand what's your take on it, because probably if I'm given an option, I'd rather do an AI assistant wherein the doctor's intervention is not required, probably 5 years, 10 years from today.
I want to make sure I understand. I believe that the question or conversation is around using front-end technology to solve your healthcare issue without involving a doctor if one isn't necessary. Is that the
That's
sense?
correct.
Yeah. So anyone can respond to that. Yeah, please, go ahead. Rajendra, you go first.
So I want to respond by asking a question back to the audience. How many of you are afraid going to a doctor? Can you raise your hands? Frankly? How many of you are afraid going to a doctor? That's what I'm asking. So I see a few hands coming up there. Yeah, you too as well. How many are comfortable going to a technology to seek health information? Can you raise your hands? Well, I see more answers. I think that kind of clarifies that it's more an issue of trust than quality. I think what technology will do the most is change the way doctors look at patients, and then the patients the way they look at technology. How do you bridge the divide for specialties is going to be a very different approach. You know, I think what I like about AI is that you actually start being very precise. You don't use the word please. You don't ask the wrong thing, missing out a word. It doesn't give the right answer. Every patient will also get to understand, or rather more population will get to understand how do you speak to technology. I hope they will start talking to doctors in that manner, telling them the right thing in the right manner. And I hope doctors will realize that they are not competing with doctors, they're competing with technology for the same patient. That will change a whole lot of things.
Please, go right ahead.
So my answer is very simple. In acute care, technology is an enabler, but no substitute for acute care. In chronic care, technology can be an enabler for adherence, and you can save a few doctor visits. It can give you those nudges from lifestyle. It can ensure that the medications are taken on time. So AI assistant will replace a lot of PIs or surgical assistants and so on and so forth. That point taken. But if you ask me whether it completely will move the gear, I think it's not prime time still. And I think we still need to generate evidence base. I think the evidence base is woefully lacking. And I think that's my big challenge, because we are not looking at the legal and the regulatory oversights on it. And globally, we are now litigant. So tomorrow we see that you go on AI and you get something completely erroneous, you are liable. So I think it's not it's a very good enabler as long as it is supervised. So I think it is still an era of supervised care. And I don't think we can just leave robots on the streets to manage everyone.
I think an interesting angle on this is why you asked the question. I mean, you had a reason, but I mean, as a consumer of healthcare services, it's of interest to me. I think there's a category of things that you go to the healthcare system for that are very transactional, and you just want it done, whether it's a refill of a prescription. And again, these may be US things that I don't know, but there's a bunch of them. And we make it really hard for patients to get those things done. We just put all kinds of barriers up, I'm not sure why. And so companies spring up that will do it online, or the next thing, maybe you just get an AI bot to do it for you. To your point about acute care though, when you need someone who's got 20, 30, 40 years of expertise looking at a problem because you feel sick, I think you go directly to the person at that point. Yeah, anyway. Other questions? Or
Good evening.
did you want to, anybody else?
Hello,
want to
good
tackle that
evening.
one?
Good evening. I'm Dr. Raviraj on the left side. So as a doctor, my question is for the doctors in the panel as well as non-doctors in the panel. The question is, where would AI stop in an intervention if it goes wrong? And where would doctors step in? So my non-doctor peoples in the audience as well as in the panel, I would like to give a scenario. Suppose one of the panelists said ki AI is able to diagnose migraine and is able to prescribe the medicine for that migraine patient successfully, which is good. But suppose that patient does not give the history that he had kidney failure 5 years back, or patient is not able to tell what kind of pain he is having. Like there are different kinds of pain, sharp shooting pain, throbbing pain. Based on that we diagnose. So even if the patient is not able to tell us कि sharp shooting है, we can ask कि चक्कू चुभो रहे वैसा लग रहा है, whether it is feeling like a pricking sensation or whether it is like someone is punching you. Like this, in layman language we can ask those questions if patient is not able to articulate. How would AI solve it? Because if AI is able to take that prompt and ask the leading questions based on what information it is getting, it will lead up to a different diagnosis than what patient is having. And it can be a disaster in critical patients. Suppose instead of chest pain, heart disease ka patient is diagnosed as a gastric reflux patient. AI will prescribe the medicine. The patient will take that medicine and will not go for the test that he should have gone for. He will not go for ECG, not go for echo. Where will be the cap? Where will be the limitation where doctors should step in and AI should stop? This is my question.
I want to give our panelists a chance, and this will be our last question, so take it thoughtfully. I would just, before we get other responses, point out that all those things that you just mentioned, people do too. They make the wrong diagnosis. They send patients home from the emergency room when they should be hospitalized. So I'm not defending AI to say that, because again, I'm all about human in the loop, but just to say that we sometimes are not maybe taking our own error rate into account. So please.
I think he's brought out a very, very valid point. I think two things are very important when you're using AI. One is transparency and accountability. Transparency, when you're using AI, you should be transparent in admitting that with the patient that yes, you are using AI for this interpretation, and then ultimately the decision maker is the physician. So he is going to be the interface between the machine and the patient. That is for sure. And I also feel that the regulatory authorities will now consider, and it will evolve in a way that the accountability ultimately lies with the doctor or the physician. I don't think we are ever going to have a scenario wherein the accountability lies with the AI.
Check.
We're going to leave it there, folks. I'm being given the hook. So please give a good round of applause to our panelists, and we thank you very much for your attention.
Thank you, Dr. Joseph Kvedar, for chairing that session so beautifully. It was a very insightful session. And thank you to all the panelists.